Wow. Okay. This is a follow-up for everyone concerned. This is a follow-up from 2 weeks ago. Health screening and cancer. Now, oh my goodness, there are so many cancers and so many um, screenings that our health providers put in front of us or show us a chart and tell us the reason why, hey, it's time to have this colonoscopy, or hey, we need to go send you to urology so we can have them check you out and look at your prostate and see if your prostate's in decent shape. And if not, go from there. So I chose two screening, well, two cancers to screen in particular. One is breast cancer because it's a very big deal. And prostate cancer. That's another one that's a very big deal. Whoops, I forgot. We need to put this up on the screen here. Thank you, Linda. And we are just waiting to get on the screen. Okay, so I'm going to advance this here so we can get going a little bit. So what are our concerns as we age? Okay, I think I can use the toggle buttons. Maybe. Can I use the mouse? Oh, there we go. Aha. Okay. So I have a couple of charts here. So health screening by age. So according to this source, Mercy One, you can see there's certain health screenings that can begin as early as 18, even. There's cervical cancer, um, cholesterol. Now, these aren't all cancer, these are just health screenings. There's flu vaccine, there's wellness visits to make sure that, hey, we've got you covered. That's from 18 to 39, so as young as 18. All right. Now, I don't know if that includes human papillomavirus, but I think that fits somewhere in here too. Now, about age 40 all the way to 65, we're really concerned. If those of you who were here the other day and you heard it's Dr. Diaz, I believe his name, he was talking about blood pressure and some new guidelines as well as blood pressure in the brain. Well, we are very serious about blood pressure around 40. Same with screening for cervical cancer. We're taking a notch upward about that point. We're also taking cholesterol very serious. Colon cancer screening starts at about age 45, although my doctor waited until I was 50 to get my colonoscopy in. And of course, at that point too, after 40, the flu vaccine recommended, mammogram. If you're a woman over 40 years of age, you are at risk. So they do push that, recommend that. Shingles vaccine starting at 50. And yes, at 50, I got my first shingles vaccine. And of course, wellness visits. Now, I got wellness visits nearly every year after about 45. So those continue now. They've been every year since then. Now, 65 and older, all right? Now we're talking about blood pressure here, a little bit like above, where it's every 2 years. We want to really check that out and see what we're dealing with. We're still taking it very serious at 65. Okay, so a couple times a year, blood pressure checks are made at the office, and then probably encouraged for you to check it on your own at home and at other times. Cervical cancer, about every 3 years in women, about the same rate as it is in women who are between 40 and 65 years of age. Okay. Because as we age, incidence of cancer tends to increase. Okay. And it could be simply due to age, our immune system, our ability, the cells in our body to regenerate and regenerate normally versus regenerate with some abnormal results, either due to, long time exposures to things in our environment, for instance, food we eat, for instance. Cholesterol, only once a year. Normal colon cancer screenings begin around age 45, but they continue beyond 65, and so on and so forth with the rest of age 65 and above. It just seems like as we get older, we have more of these health screenings that we are encouraged to, well, to participate in. Okay. Usually the doctor is pretty good about, hey, you're X and such age, we should get this done. Okay. That's typical of how they'll broach a subject, unless, of course, you're proactive and you say, hey, I'm X and such age now. When am I going to get this test? Do I need this test? Can we talk it over? And then it's a discussion between you and your healthcare provider. So hopefully that makes sense. All right. Now I'm going to show you yet another. This one's more specific though. This one is specific to cancer screening. All right. And you can see up here, F, of course, for female individuals by birth, M for male individuals by birth. So if you go and look at this timeline, starting at 21 years old, we have these discussions about cervical cancer screening, young ladies right around that time. Okay. And so, whether or not is that something in the family? Let's take a look kind of thing. Let's see if there's anything going on. So an actual practical visit. However, as we move along to about age 40, we begin having a discussion about breast cancer screening. Now, that depending on the health system, that may be earlier than 40 or slightly later than 40, that becomes a very serious discussion between you and your physician about getting this done. And hey, you need to be serious about self-examination when it comes to things like lumps and abnormalities. And that is no less true for young men who should be doing self-examination of their testicles, their scrotum, and looking for any abnormalities that way as well. Now, we move along to 45 years of age, so we're in the middle of middle age at this point, okay? So we start talking about colon cancer screening and consider starting that there pretty soon. It depends on one's health background, symptoms and signs, family history. I remember several times going over family history with doctors as I moved from one doctor to the next and having to bring family history up into the discussion overall about, in my background, there's this, or there's this, or I was exposed to this. So as we move along and we reach about 50, now breast cancer screening at 50 is something that should be started if you have not yet started it. And if I remember my wife, she had already started breast cancer screening, but she also had a history of cancer in her family. So she was much more concerned about checking out these places where, cancer might be a risk for her. So she was much more aware of that. And so I think she started screening for breast cancer in her mid 40s. I think that's where it started for her. But usually they're saying about 50, hey, take it seriously. Let's start getting you screened. Let's get a mammogram. Let's get this going. Now at 55, I started this discussion earlier than 55 with my doctor. In fact, it was around the age of 50, around the time that I had my colonoscopy, my first colonoscopy. We talked about prostate cancer. I had started seeing a urologist regular basis, PSA exams every year on an annual basis, keeping track of that. So there's a graph in my chart that shows what my PSA results are or have been like over the last 12 or so years. Also, the physical exam, which tends to be very accurate or much more diagnostic for changes. And that's the same thing with women and breast abnormalities, is that physical exam to, hey, you know what? Yeah, this doesn't feel right, doesn't look right. Same with the prostate exam. The prostate under normal situations ought to feel like this. Shouldn't be painful when pressed upon, et cetera, et cetera. So they're looking for certain things on a physical exam. Okay, this is just normal routine cancer screening. In fact, I just had my last PSA and my last prostate examination late in December of 23. Now we come along around 65. Now it says, have a discussion about when to stop cancer screening, and that may not be completely stop. It may be, let's talk about screening less frequently, maybe, depending on you, depending on your symptoms, okay? How you're feeling at this point, things like, all right, if you're doing self-examinations, does this feel right? Is there anything new going on? Are you having trouble urinating, or is it urinating weekly, or are you urinating quite frequently, more frequently than you're used to urinating? Is there blood? Are there areas on the human breast where you notice that there's dimpling on it in the wrong direction? In other words, inward, even at the area of the nipple, if there's a dimple that pushes things inward, that's usually not a good sign. So you're doing self-examination. A lot of it is on you to follow up. And it's like, if you notice something, get in touch with me right away. Don't wait. So there's that discussion about, do I need to see you next year? Or do I need to get this test every year, every 2 years, etc. So hopefully I'm making sense about how this timeline of screening works, and it's going to vary medical system to medical system, and maybe even physician to physician, who may be privy to certain studies that show this or that. And maybe at the point of 65, they might say, let's play it by ear. I'm going to keep your case open. You're welcome to call me anytime and get seen anytime. That kind of thing. So maybe at 65, you're at that point, depending on problems before then. Sorry, I kind of harped and harped and harped and harped on that. But as a nurse screening for these things, and going over them with patients on the units as they're being discharged. Hey, look, you've got a colonoscopy coming up. And hey, you have a flu shot coming up and pneumonia. If you don't want to take it here, next opportunity you get to your doctor's office, please go in and talk to them about getting this. Okay. So these are things as a nurse, I kind of naturally reinforce.
But I think you made a really, really good, strong point that regardless of whether you need to do screenings, you need to see your doctor on a sort of regular basis.
Yes.
The exam.
Yes.
Get an examination, whether you get a screening or not.
Absolutely. And I still see my physician at least once a year. At least blood is drawn, including the PSA. And we talk about, all right, how are you feeling? How is this going? How is this going? You would have called me sooner if there was a problem here, right? You're a nurse. You should be knowing this. How well do you know? So he relies on me, but not everybody going into the office is a nurse and examines these things for themselves. And so a little bit of education in these areas goes a long way to the individual patient. Okay, let's move on. So, okay, when should I be screened? Again, this is a much simpler looking graph. And these are certain other kinds of cancers, okay? And this is by, oh shoot, it doesn't have the source. It just says at the bottom, lung cancer screenings are only recommended for those with a history of heavy smoking within 15 years of testing. Now, okay, depending on the source, that may be how, and that may be how, why they got the numbers they got here. So they recommended around 40, as early as 40 for breast cancer screening. Cervical cancer, which is quite deadly, they, and that's probably a lot has to do with human papillomavirus and the way that is spreading and moving about. They recommend that all the way into your early 20s if you're a young woman. Start it then. Talk about it with your physician at least then. Colorectal cancer. Okay, that would be both male and female. And actually, breast cancer, men have a risk. It's just not nearly as high as women. I'll just say that right now. Women, hands down, have the much, much higher risk of breast cancer. Okay. Colorectal cancer. Now they're saying, to your mid 40s for that, but if you have a family history or symptoms, you may want to go in earlier than that. Now, lung cancer. They're saying between 50 and 60, but I would say it depends on the situation. I mean, it says here at the bottom, they've been smoking here within the last 15 years of being tested, and perhaps they're still smoking. So, um, gosh, I would think they would need to start getting tested much younger than their early 50s. That's my view of it. And I think if you looked at other sources, you might see different numbers. Because I'm kind of surprised my grandfather, who smoked all his life, didn't die of cancer. He died of emphysema. Yeah,
The recommended span is from 40 to 60.
yeah,
They're still having me remember.
yeah. This is, I think the last screening, let me see if I have the last screen up. What do they say? When it comes to screenings, they say at 65, you should have a discussion about, hey, is it time to stop some of these screenings or not? I mean, and then it becomes, it needs to be a hard discussion between you and your provider, whether or not, hey, is this necessary at this point? Do we really have to do it as often as we're doing it? And I think that's a valid discussion to have. Absolutely. I agree. I agree with that question and where you're going. All right. So, all right, here we go. This is what prompted me to look at breast cancer and prostate cancer. This graphic is from one source, and they're looking at men and women through the age. Okay. They're looking at things like leukemia, different skin cancers. Now, I see breast cancer. If you look at that, 25. All right. 25 all the way to 75 plus. Okay, maybe that's where they're getting the screening thing. But what, what are the real numbers involved in that 70 to 70 to 80 plus? And how often should they be getting the same screening? Now, it may have to do, well, what if you have, breast tissue that's super dense? I think I may have mentioned this last time, and they have now newer technology, unfortunately, same kind of technology, mammogram. They said under the standard mammogram, it will be a little bit harder, possibly, if a woman's density of their breast tissue is more dense to pick up on cancer, whether or not there's any presence of signs, symptoms, or tumors, anything felt, or like, there's nothing odd about this side of my chest at all. So again, I guess that's another one of those things to talk about with your provider, given that, hey, I've had nothing but negative mammograms and tests all the way up to this point. Do I really, 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 really have to have this as often as you say, or at all at this point? Can we go back to, you know, self-examination, or you examining once a year or twice a year, doing an actual physical exam versus putting you to the mammogram? So again, I think that's another serious discussion to have, another serious discussion. So for men, on the other hand, you can see some of the cancers here. So leukemia seems to, that hits a lot of kids. Then you have certain other tumors in men 15 to 24. And then we start looking at testicular cancer and whether or not that has any relation whatsoever, but it's a close proximity to the prostate. We start thinking more serious about prostate cancer around late 40s to early 50s. And then even into the 70s, because I think the mortality rate of those cancers tends to be higher than it is in some of the other cancers that they've measured. And for me, that's why I thought, oh God, okay, narrow it down to two: breast cancer, prostate cancer. Makes sense to me. So, all right, which screenings are concerned? Prostate. Who does the screening? How's it done? What, uh, I guess I'm missing a word. What are a few of the tests involved? I'm a poor editor. Uh, what happens if the test is positive? Okay, well, on the other side of that coin, what about breast cancer? Who is doing the actual screening? How does that get done? What are a few of the tests that might be involved? And what happens if something's spotted either on the physical exam or on a mammogram? These are questions you might ask too. It's like, well, who does the prostate screening? Is it you, doc? How's it done? So I can see patients asking some of these questions maybe for the first time, maybe if they've never had it done before. So some signs and some symptoms. Now, are these all the signs and symptoms? No, these are just some of the signs and symptoms in general that we will see. And I pulled some of these from Davis and some from the American Cancer Society. So for prostate, we're looking at possible interrupted, maybe a weak stream of urine. Okay, that might be new, in fact. Or, God, it seems like every hour I'm getting up and I have to go. All right. Or I have trouble getting the urine out, or it's painful to push the urine out. Or for some reason, there's blood in my urine, or perhaps blood in my semen, on the other hand. Or there's pain in your back, groin, hips. Another possible sign something's going on. Now, in breast cancer, all right, let's say maybe an unusual looking lump that wasn't there a couple months ago, or lumps. Maybe there's more than one in the breast area, but also, since the breast very close to the underarm, hey, what the heck? There's something going on here in the underarm area. That's not right. Change in size or shape of the breast is a concern, especially if that's brand new. Any dimpling or puckering of the skin, and with that, there actually might be discharge, might be bleeding, might actually be infectious looking type of drainage coming from that area that's dimpling. And if, in some cases, a nipple that's turned inward might be an indication, not always, but it might be an area of concern. And again, discharge, redness at that area, also redness, pain, scaly looking at that area where there's redness and dimpling in that area, definite cause of concern. So, all right. I put these on both sides. I put one on one side, one on the other as I go through some of these different processes. So I just thought, hey, it makes sense to do that. So diagnoses, screening and diagnoses. So DRE, something most men don't like, but hey, I got used to over time is the digital rectal exam. So that's one way they can get in and they can press on the prostate to see if this is, this is a normal state of affairs for a certain person's age, or this is not right. And they know what they're doing when they get up there and they start examining. Okay. So they know this is a normal or this is not a normal prostate. The PSA blood test, prostate specific antigen. Okay. There's usually, if there's a tumor or if there's abnormal growth, cellular growth in the prostate, there'll be an increased amount of this prostate specific antigen in the bloodstream, which might be a marker of a problem or a cancer in the prostate area. Now, they can do an ultrasound of this area. It's a transrectal. All right. Usually what they do is they don't just do that alone. They do the ultrasound, and the ultrasound is a pretty good exam. But typically, if they decide to do that, they want to get a biopsy. They want to assess the cells. So they want to get a sampling if they can at that point of the tissue that's suspected of being cancerous. So that's another possibility. And I believe they put them under general anesthesia for that one. Now, with breast cancer, all right, one of the first things is a physical exam. Maybe you as a patient identify it. You brought it in and say, doc, this is not right. Okay. Doctor looks at it and says, okay, how long has this been? All right. When did it start? Has it beginning progressively worse? Questions. All right. Physician looks at it and says, you know what? I want another doctor to look at it. And a referral might be made at that point, or more tests might be made at that point. So a mammogram might be ordered at this point too. And there are a couple different kinds of mammograms, again, according to someone who has more dense breast tissue versus someone who does not. Okay. And might be able with a normal mammogram to pick up abnormal tissue, or they may have to use that other type of mammogram screening that can actually penetrate denser breast tissue. But here's the thing. With mammograms and breast tissue, in many cases, a mammogram can pick up a tumor before you can actually feel it, because when it's looking at what is what's possibly abnormal tissue deep enough that you don't feel it, but it's there. It's like, we need to do something about it. We need to go in, biopsy, see if this is, precancerous, cancerous. So there's a very good reason then for having that mammogram screening. Now, ultrasound MRI studies can do more detail on an identified lump, tumor, or another kind of abnormality in the region of the chest. I want to say the breast and adjacent areas like the axillary area, or maybe even musculature right underneath that. Yeah, if I said that right, yes. Now, with these ultrasounds and MRIs, et cetera, it may necessitate a biopsy to pull a sample and examine the cells. So altogether, good possibility. How are we doing out there in Zoom land? Following? Are we good? Okay, I'll keep going.
Yes.
Okay. Now, risk factors, both of these side by side. Prostate cancer, is there a history? Is somehow in all of this, is there an identified inherited gene marker, which can only be done by special studies if something like that is already there and known? And then maybe that individual gets tested to see if they have inherited this gene for cancer at the prostate. Now, something very similar exists also for breast cancer, because there's definitely an inherited component there. If your mother had breast cancer and had maybe breast cancer in both breasts, did your mother's mother also have breast cancer? That is, just because familial history right there, you may want to get tested as early as it's possible or feasible to do so, since, my God, this took my mother and my grandmother. So, this is pretty heinous. I want to find out. I want to get this tested. I want to get this treated ASAP if it's there. Okay. Prostate cancer, race and ethnicity happens to play a part. African-American men seem to be at higher risk, at least according to the studies. I didn't have time to look at those studies further. But apparently, at least in the data, African-American men have a percentage edge over other populations of men in, prostate cancer, incidence of prostate cancer. Okay. Now, again, in women, we are talking about family personal history of breast cancer. But what if that person, what if that woman had had prior radiation therapy to her chest? Okay. I don't know, for whatever reason, or radiation therapy, maybe multiple chest x-rays. They didn't outline specifically what that meant by radiation treatment versus chest x-rays. I would say that what they're speaking of is that if they had prior radiation therapy to shrink a tumor there and something came back, that this time it might be very aggressive, malignant. So it's very possible they had small inklings of abnormal tissue there, and they were able to take care of it with radiation without having to do a partial or a radical or something else. And so they had the radiation therapy there, right? And maybe that eliminated the cancer. Yay! You're in remission. But what if it comes back? Well, was the radiation therapy part of that? Did it have something to do with it? At least that's a question they're asking. Is there a possibility? Now, with prostate cancer, where you live, your nationality. Do you live in North America, Asia, parts of Africa, maybe northeastern Europe, perhaps Australia? Okay. It seems that if you live in certain parts of the world, prostate cancer seems to be a little bit higher in those zones than it is in others. Now, at the same time, I should have said, well, In these other areas, it tends to be less, but I didn't list those. Wasn't enough room on the slide. Now, on the other hand, alcohol seems to play a part in breast cancer. What part, what percentage it plays is a good question, though. But it's listed by the American Cancer Society. Also, if you're a woman and you're Caucasian, you are at greater risk of breast cancer. At least that's what the numbers seem to be showing. Now, in men with prostate, or at least at risk with prostate, diets that are very high in dairy products or meat, red meat products, and they lack perhaps regular exercise, and perhaps weight has something to do with it too. They increase their risk. What that looks like exactly, I'm not completely certain, but at least from what I've read, it increases risk. Now, women who have denser breast tissue have a higher risk, and it may be that they have a higher risk because the denser tissue will hide a tumor, or it'll hide the beginnings of cancer. That's what I mean by denser breast tissue, harder to see through. And so you need to have that other type of mammogram technology that can pick it up earlier and maybe see it. And that's why I put that under risk, because, hey, a normal mammogram may not pick that up. Does that make sense? I hope. A normal mammogram may not pick it up if a woman has denser breast tissue.
Don't we call that a fibroid?
They might. I mean, there are others that they pick up, things that they're ruling out as they examine. Fibroids might be part of that. Other benign, I want to say other benign intrusions also doesn't make them doesn't make them healthy, but there are other intrusions also that they look for. So yes, definitely. All right, so treatments, very, very much in brief, because there is so much detail on the website about treatments. I was hard pressed on where to start. Now, certainly surgery is an avenue to go for both prostate and breast cancer. We're talking about sometimes it's radical for both, which, if we're talking about the breast, we're not talking about a simple removal of a lump and retain the rest of the breast. Maybe it's a total mastectomy where we're talking about removing the breast itself and lymph nodes close by that actually showed positive when taken for specimen for the same cancer, or a radical, which means breast lymph nodes, muscle tissue underneath. So we're talking deep, and other tissue surrounding the breast, and also part of the chest wall, and perhaps up into the axillary area, where we start thinking about, that's where a lot of our lymph nodes like to hide out. So that tends to be a very, very serious surgical procedure. For men with the prostate, first thing I think about is TURP, because I took care of a lot of TURP patients in med-surg, okay? That's transurethral resection of the prostate. So they actually get to the prostate from that route. They have other ways of doing it. They have a high intensity ultrasound ablation, which has lower risks of some of the side effects that a TURP. With TURP, the guy might end up being permanently incontinent, permanently impotent, and there may be some other problems associated with that too. But with the ablation part, side effects are at a slightly lower risk that you're going to have significant problems in those other areas that a more radical approach might take. Now, for women, I mean, a lumpectomy, which spares tissue, sounds like a really good approach if the tumor is isolated enough and they can get at it. It's like this hasn't gone anywhere. There's no evidence. Removal of the lump, sew it up, heal. That would seem fairly darn reasonable. But there are other ways to use other therapies like internal or external radiation if they can pinpoint it enough, especially the internal part. If they can get the radiation inside, implanted inside, close to the tumor, shrink, 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 that may actually be part of that. If we can shrink it, maybe we can remove it. That kind of thing. Now, there may be, with some of these on the other side of this coin, when we're talking about prostate, I mentioned these: incontinence, erection, impotence. I already mentioned that. A lot of these procedures with the prostate are likely to lead to some degree of those problems, okay? However, radiation therapy, internal and external, have been used if the tumor is such that they can use that type of therapy. If it's small enough, if it's in the right spot where they can get the seeds for the radiation that they need in and around that tumor to shrink, 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 and then at some point either remove, or if the radiation by itself shrinks it enough, maybe chemotherapy will take care of the rest. Possibility, without radically getting in there to remove it. And with women, another possibility is chemotherapy, and that might be regional or systemic therapy intended to kill the cancer cells. Now, they may use a regional approach to get at the tumor versus, well, guess what? We have to put a permanent, semi-permanent port in here in one side of the chest or the other, or a catheter that's meant to stay in here for a long time so we can give you the proper medications. That has other consequences when it comes to illness, nausea, vomiting, and other things. And men, they don't go get away scot-free from chemotherapy when it comes to that either. I mean, both men and women may profit from hormone therapy because sometimes the tumor is going to grow because of a certain hormone that's present. And so with certain hormone therapy, they shut that hormone down inside. And by doing so, they stop the growth of that tumor, if that makes sense. They can reverse it by using a different hormone that will shut that hormone process down so it can no longer feed off your body's own hormones that are part of making that thing grow and spread. So that's one of the newer therapies. Maybe it's been around for a while, but it blocks growth and development of cancer cells in either case. All right, are you still with me? Everybody with me on this so far? This is heavy stuff. And I'm glad I narrowed it down to just two things. Oh my gosh. So take a look at this. Interesting. This is a probability chart. We're talking about age, one side, and we're talking about probability of developing, in this case, prostate cancer. All right. Age 49, you have a 1 in 400 chance. Okay. At age 50 to 59, maybe a 1 in 58 chance. And it looks like as you get a little bit older and older, the chances go down. So what it looks like, birth to death, if you make it past 70 without prostate cancer, you know, maybe you have a 1 in 9 from birth to death probability of developing prostate cancer, which is least amount when we're talking about if you compare it to 49 years of age, that's huge. No, excuse me, I'm going the wrong way about it. Scrambled brains. Sorry. Forget what I just said the last 5 minutes. When you're younger, your probability is much better. Pardon me, I think I haven't had enough caffeine today. So the numbers, as you get older, your probability actually increases, folks. I'm sorry. I'm so sorry. I took that in the other direction. Trying to see if you're awake. No, trying to see if my own brain's awake. As you get older, the probability increases. I guess that is the point of this graph, age and development of cancer. Does that make sense when you look at it then? Kind of scary, isn't it? So look at breast cancer. Probability of breast cancer development in percents. All right. Okay. Birth to 49. Again, we're talking about a higher number as we're younger. And I want to say 1 in 52. Wow, I got 1 in 52 chances at the age of 40. But, all right, let's say I'm 59, 60, over 60. Holy cow, that's cut in half. I have a 1 in 29 chance of developing breast cancer at the age of 63 or 62, 65. And then once you get over 70, you have a probability of 1 in 16. And then all birth to death, I mean, all the way from time born to the time death, it shrinks to 1 in 8, which are hugely bad odds. But you can see how those odds increase as we get older. Starts out at a pretty good standing when we're younger, but increases as we get older. And again, it may be due to our immune system's weakening inability to fight off cancer. Cells that redevelop as we age may not develop properly for some reason. And there may be a lot of environmental reasons behind it, inheritance, something in our genes and chromosomes says, hey, we're kicking in now. We're going to give you cancer. We're kicking in. And guess what's going to happen? Boom. Colon cancer. Boom. You know, I don't smoke, but guess what? You have lung cancer or some other kind of cancer due to something in your gene makeup that kicks in all of a sudden. So survival rates, and this is just for prostate cancer in blue. However, let me draw your attention over to the very first cancer in that lineup, and it's breast cancer. Okay, hopefully you all see that. People, see how it is in the vertical? People surviving 5 years, percentage. Okay, 5 years or more maybe. All right, it's close to 90%. Pretty good survival rate. Now you can see the numbers, percentages, depending on the cancer. And this is the reason why I like this particular graph, because it covers a whole lot of cancers. And then you get over here to prostate, the numbers are slightly better, close to 100, but not quite, 98% of living past 5 years. It depends on, a lot of times, on when it was discovered. When was the cancer discovered? All right. What kind of cancer cells are you dealing with? How aggressive is the cancer? Did it spread? Can it be treated with our current avenues of approach? Can it extend life? You know, maybe we're not looking for a cure here, maybe, but we want to know, can it buy us 5 years, 6 years, 7 years, 8 years more of life? So these are things that have to be weighed out. And here they say surviving 5 years. Okay, this is just a number I guess they chose. Percentage wise, this is what it looks like. So it's an interesting graph looking at various different kinds of survivabilities. Look at pancreatic cancer. Oh my God, it's the worst of all of them. 4%, surviving up to 5 years. Huge mortality rate. That's what my mother-in-law died of. And from the time she was diagnosed to death, it was about 2 years. About 2 years. So what do? We do a lot of the same things I mentioned in the last PowerPoint about, a lot of this is on you to get annual follow-up with physicians. Check your diet, your weight. If weight happens to have an impact to this kind of cancer you worry about, then maybe find an effective way to deal with that. What if it's physical activity that you need to modify, change? What if it's the food you eat? Okay. What if it's consumption of certain other beverages, whether they're sweet beverages, whether they're beverages with artificial sweeteners? What if it's alcohol? What if it's fast foods and everything that we know to be unhealthy about it? What if it's what if it's things that, these are things that you can control. What are things you can't control? What you inherited? Genes, you can't control those, okay? Genes and inheritance, you can't control. What's in those chromosomes, and if they're there, when are they going to show up? What could trigger it? Those are some things you really can't control. What was passed down to you? What if you had cancer before and you're in remission? What are some things you can do to be sure you can stay on top of that? Because if it recurs, what can you do? What should you do? What are you and your hematologist, oncologist thinking about? Since after your cancer has been in remission and you're seeing them often enough for markers, maybe PET scans, you're talking about, okay, how often do I see you? What am I looking for still? Okay. Any updates, anything you can tell me? When do you want to see me next? In other words, proactive stuff. And stuff that you take in might include, are there medications, you and your doctor discuss, are there medications that maybe, make these cancers a little bit easier to come into my life again? Or are they going to encourage immune suppression? Are they going to encourage, this kind of cancer that I just got done dealing with? So that might be an issue as well. If you're a smoker, even if you can't cut cold turkey, this is what I tell students. Look, when you're trying to talk to somebody about smoking cessation, come halfway with them. What do you think it's going to take to maybe, instead of smoking a pack a day, what about half a pack a day? What would it take to do that? What if they smoke 15 cigarettes a day? Ask them, what would it take to maybe smoke 10 cigarettes a day and find a way to step down? It's a compromise. If going cold turkey is like, no way, I'm not going to do that. Then you find another way to put it to them. Same with drinks. What's it going to take if you drink 5 drinks a day? What's it going to take to maybe bring that down to 2? So these are discussions that I have with patients who are alcoholics, smokers, even drug addicts, that kind of thing. These are discussions that I have, and I pass these discussions, the thinking on these discussions on. That way you don't shut the conversation off. So here's some smoking cessation information. They have had it over and over and over, probably, you might shut that conversation down. Anyway, neither here nor there, but things that you would think about if you're doing some of these things. By the way, this is from the American Institute of Cancer Research, yet another resource that one can go to get to what can I do proactively? What can I do? What can I do? What's within my grasp? What's within my reach to control? And lastly, questions. And here are a few more references. Any questions? How'd I do? Did I do pretty good with just these two? Just these two? Because my God, I could talk about these two a lot longer than this, a lot longer when it comes to treatments, signs, symptoms, how to talk to patients with new diagnoses with cancers. You know, what's some of the latest information? You know, what are some of the, really important questions to ask? I could talk more about that. So how about there in Zoom land? Anything in Zoom land?
Thank you. It was very, very, very helpful.
Oh, cool. Thank you. I appreciate your
Excellent.
feedback.
Yeah.
Like I said, I think this is being recorded. It's been
Yes.
downloaded, so it should be on the website. And unless we get a request for something like this in the near future, probably I'll do something like this later on. I think the next one that I'm scheduled to do has to do with brain health. Since Dr. I think, what is his name? The PT, the head of PT in our department here, spoke about high blood pressure and the brain. Oh my God, okay, great. So he's going to follow up on some of this too. So the next one I'm going to put out there is on brain health. Yeah. Oh, yeah.
And having the recordings allows us to share with others afterwards. So
Oh,
thank
cool.
you.
Yeah,
Thank
yeah,
you.
absolutely. You know what? That's a good point. Very cool. Thank you. Okay, so you're asking, what about secondhand smoke?
Like kids right now. Everywhere you go, you go walking in the park, marijuana smoke is everywhere. And I just hate it. But how does that affect you?
Well, I got to be honest with you. Secondhand smoke is, you're getting it unfiltered for one thing. These are kids whose frontal lobe hasn't completely formed yet. I can talk to you more about the formation of the frontal lobe in young men and how they do some risky things that, oh Lord. Anyway, it's damaging. It's been shown to be damaging. Earlier efforts when we had, what would you like, smoking or non-smoking? And we're going to separate your offices by cubicles. Smoking cubicles over here, non-smoking cubicles, doesn't matter. Does not matter. You're in an environment, you're breathing it in. Oh yeah, and you're getting it unfiltered. At least the guy or gal who's smoking it gets it through a filter. You're getting it unfiltered, especially if it's close by. And this is something that has concerned me because my oldest brother smoked most of his life. I was around him a lot. My grandfather smoked for as long as I knew him. Every time I saw him, every time he came over, he was smoking a pipe. So I was breathing it in as a kid. My parents, my dad especially, but both of them, worked in an office for decades where everyone smoked in the office, but they didn't. They come home, clothes smelled like an ashtray. And I could swear, I remember when I was really small, 9 years old, I come up to my dad and I said, "Are you sure you haven't been smoking?" I said, your over jacket just reeks of it. You know, I didn't say reek. I didn't have that in my vocabulary, but I said, it just smells like cigarette. And as a kid, of course, with lack of a frontal lobe that was fully formed, I tried cigarettes because it was a cool thing to do. And in my high school at that time in the 70s, they had an area for kids to smoke. Talk about talk about encouraging a wrong thing to do. And in between classes, sure enough, a whole bunch of high school kids were smoking in this big area called the quad where there were ashtrays everywhere. Smoking, come to class, smelling like an ashtray. You know, some of them would put the cigarette out right before entering class. So it does do damage. There's evidence regarding secondhand smoke. And when you think about the smoke in general and damage it does to the bronchioles, the bronchus, main bronchus, the destruction of blood vessels, vasoconstriction. Oh my gosh. Carcinogenic elements that are in cigarette smoke. Oh my God. A gal when I was going to grad school, she labeled them all and put them out on a big sign when she was presenting on cigarette smoke. And it was covered in different carcinogens from your average cigarette. It was mind blowing. This was allowed into a cigarette and you could smoke it. You could draw it in. You could blow it out, you know. Anybody around you would get a whiff of that. And you know, they used to allow smoking on airplanes, restaurants, buses. They had smoking areas near the units. Some of the gals I worked with were still smoking when I started nursing. Uh, and they would just simply, there was a door. They'd simply just go out into this little open area that everybody, this little area that was quiet. There's a big ashtray out there, and at any one time during the day, there'd be 3, 4, 5 nurses out there smoking, maybe a doctor smoking.
Shop after one at the nighttime. Patients, roommates, lit up the cigarette, the other one was on up. And,
Boom. You know, there are patients. Yeah, there we go. There's a sentinel event because I know a lot of people walking around with an oxygen tank and a cigarette in their mouth. Holy cow. And I had to remind them, I said, you realize you're kind of a walking flammable bomb here. I know.
Marijuana smoke is dangerous.
God, I would have to clarify that a little more, but I would have to say yes. Marijuana cigarettes in most forms don't even have a filter on them. And depending on the way they're wrapped and how they're processed compared to tobacco, there are damaging components to it. And as a stupid kid, I tried marijuana when I was a kid too. But yes, and this comes out a lot of kids ask about marijuana versus cigarettes. Well, it's not a cigarette. I say, yeah, no, it's not a cigarette. It's a marijuana cigarette. I say, you're still smoking leaves, and those leaves that have to have been treated in some way, and the wrappings they're in have to have been treated in some way.
Is it really true, is there any truth to a secondhand high? You know what I mean? You just,
Yes,
there is.
there is, depending on how much, how close, and how much. I mean, if you're in an enclosed space, you could. If you're in an open air place and you're near people smoking, less likely. But if you're in an enclosed space and somebody on the right of you, on the left of you, in front of you, smoking marijuana, which, okay, another bad example, but I remember in 1980 going to a concert and everybody was drinking and they had to leave their glass bottles out in the parking lot in garbage cans and other bins. But they took cocaine with them. They took marijuana, they lit up because everybody had lighters. And it was a thing to light your lighter during a concert when you liked a song or you were in agreement or whatever. And so the masses had lighters and they were smoking. And I literally came out of there with a high because there were so many people smoking. This was in the Oakland Arena. And my God, I wasn't driving, thank God. But and that was one of those situations where there were drugs everywhere. Dangerous, 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 dangerous. Oh, Jesus. All the drinking stopped outside. And I mean, every bin, basket, garbage can filled with bottles and cans because they couldn't take it with them. So they were drunk or nearly there when they went into the arena. And they continued this afterward. That's just one example. So, yeah, but yes, secondhand smoke is a real thing. I think it contributed to some of my dad's arteriosclerosis, in fact, because from the time he started working for the government, he worked in an environment where smoking was acceptable and everyone around him smoked. He didn't smoke. Even when he was in the army, he didn't smoke, but everyone around him smoked. And so, yes, I would say it had a very big contributing factor, that and his sedentary lifestyle as he got older. But, being around cigarette smoke for 30 years, working for the government, in an office, closed in, not very good ventilation, not very good air conditioning, hot during the summer, cold in the winter. Continual smoking. There was a haze inside the office. It was a big room, very big. A haze in the office, almost gray from the cigarette smoke. I know because later on I worked for their building maintenance company. I used to clean their windows inside. And the water that came off the windows was black as midnight from cigarette smoke. It attached itself, all the particles, dirt, everything in the air, attached itself to the inside of the window. It looked worse than the water on the outside. That's how black it was and dark it was with that stuff stuck to it. So I would say there's enough evidence out there, and they've been talking about this for many years, about the secondhand aspects of smoke. Oh my gosh. If you grew up in that era, a lot of kids today didn't grow up in an era where you had secondhand smoke as much of an issue, like going into a restaurant in 1983. Can I lead you to smoking or non-smoking? And I thought to myself, what bloody difference does it make? I can smell their cigarette smoke way over there. I can smell it over here because air currents take it that way. There's not getting around and away from it. I thought it was a joke. I didn't say so, but I thought it was a joke. So, yeah, weird, huh? I wondered what we really knew about secondhand smoke and smoking area versus non-smoking area. The government really knew this didn't make any difference whatsoever, but to placate the public, let's cut things in half. Let's put non-smokers over here and let's put smokers over here. Okay, it'll placate them for a while. But anyone who had eyes that were open and ears that were open, they could just had they could sense something was off about that, they could say, that's BS. That's BS. Anyway, sorry. That took me off on a soapbox. You know, because I see secondhand smoke as a huge contributor to my dad's coronary artery disease and has arteriosclerosis. Big contributor. Well, that and his diet, sedentary. He didn't smoke a cigarette in his entire life. Not one. But secondhand smoke, 30 years at least. Not including his years in the military. God. So, but it wasn't cancer that took him. It was an MI, a big one. Killed him within just a few moments. I wasn't there. I was on my way home from vacation 2 days before the new year, 2010. As soon as I got home, it was like around 11:30, midnight. My sister had called, said, Dad's gone. And I said, what? Gone where? Where did he go? She said, no, Dad's gone. And I said, where are you? And I drove over. Sure enough, pronounced dead right there. 12 lead, had everything hooked up, no life. But he'd had 5 bypasses, bought him 15 extra years of life. He had so many blocked arteries. But yeah, never smoked a cigarette in his life. But yet I still think secondhand smoke had a huge impact. But lack of exercise, sedentary lifestyle, a diet that wasn't that great. I had already vowed long before he died that I wasn't going to head in that direction. And sit in front of a television in an easy chair and watch college football. I don't watch college football. I don't watch professional. I don't watch TV at all. I walk. I take the stairs. I don't smoke. Yeah, now that's my vice. And part of it is like, well, okay, some of it, yeah, I like to do, some of it I have to do. So that's the other side. I don't watch TV all day, but this is like watching TV. This messes with my circadian rhythms too. Anyway, I'm stopping this PowerPoint. I will see you all soon. Hope you all have a great weekend. And I'm going to press the leave button here with the stop share.